Palpitations, what a boring topic. I'll have to do something to try and spice that up. Now, I suppose I should start, everyone starts by saying, can you hear me at the back of the room? So I say that because my previous patient, David Longy, told me that he once addressed the audience that, and somebody stood up and said, yes, I can hear you perfectly clearly, but if there's someone else here who can't, I'll gratefully swap the seat. Anyway, coming on to this. Let's have a look and see what we've got. One of these should advance the slide. Let's try that one. Now, this is what my colleagues have served me up. A very standard case history. A 45-year-old female. This is the first time she's ever had symptoms. She's asymptomatic otherwise. Nothing to find on examination. Nothing to find on her ECG. And so the message here that I'm supposed to say is, well, this is very, very benign. We don't have to worry. You don't even have to refer this patient to us. However, some of you sitting there will say, well, that's all very well for Dr. Smith to say that, but when I send this sort of patient in, he comes back and he's done a Holter and a 12-lead and an echo. So why doesn't he practice what he preaches? Well, let's just have a look and see if I can defend that. So the history in this lady was of very typical for extrasystoles. I mean, if someone gets chest pain walking up a slope on a cold morning and it goes away when they stop, there's only one thing that can be. If someone says, I feel my heart missing a beat, and then there's this enormous thump, this is the only thing it can really be. And when we have a look at the ECG, we can see that we've got this extra beat here, which is usually not felt at all because it's so premature the heart hasn't filled properly. And then there's this compensatory pause and the heart fills with more blood, and so that next beat after the PVC is a really powerful one. And some people, it's very dramatic. They say, it feels as though my heart's almost leaping out of my chest. So we can make the diagnosis from the history. Okay, so what now would make me a bit more suspicious? So here's our history. It's slightly different now. My sister drowned. Well, we need to dig into a little bit further, and we find, well, you know, if her sister was a round-the-world sailor and fell overboard, that would be one thing, but the sister actually wasn't a bad swimmer. She won cups at school, and she drowned in Lake Taupo in still water, and so this is a real red flag, we would say, particularly if we can advance the slide, which it isn't. Can you advance the slide for me, please? That a family history of unexpected death is always a red flag. Now, it may be that these palpitations have nothing to do with that family history, but it needs to be sorted anyway. And so when we take a family history, you need to ask about the parents, we need to ask about the siblings, and it's good to ask also about the grandparents, because any of those people, if they had a premature, unexpected death, that's something that we do need to look into further. Next slide, thanks. I seem to be able to advance it. So let's go back to our history again. Husbands are sometimes useful. So she's sitting there and she said, well, don't you remember that faint you had, dear? Well, what do we make about that? Next slide, thanks. So if we got scenario A, I would feel totally confident this is a vasovagal episode. It's in a typical situation, getting out after a hot shower. There was a preceding feeling of unwellness. People are often not quite right when they have a vasovagal episode, and the husband said she looked white as a sheet. So I'd be very laid back about that. I'd still get an echo. I have one of my working rules, if you faint, you deserve an echo. So I'd say to the people, look, I'm getting an echo, I expect it to be normal, I just want to tick that box. But I feel very relaxed, and I don't think there's anything bad going on. Next slide, thanks. But here's scenario B. Patient was talking on the telephone, suddenly lost consciousness without warning and was incontinent of urine. Totally different history. Yes, once in a blue moon that might be vasovagal, but we say that's an arrhythmia until proven otherwise. That patient needs a very full workup. Next slide, thank you. And so the red flag, unheralded syncope, is always an arrhythmia until proven otherwise. Next slide, thanks. So let's have, next slide please. Let's have a look at the next bit of history. So now, the physical examination is not quite normal. There's a systolic murmur present. Next slide, thank you. So it's still most likely this is an incidental flow murmur. In healthy people, a murmur usually is just turbulent flow through a normal valve. But there might be mitral valve prolapse, and as you know, there's an association between mitral valve prolapse and arrhythmias. The risk of sudden death is extremely small, but very rarely sudden death may occur. And of course, it means a ballooning mitral valve and the possibility over time that there may be progressive mitral incompetence. So it's something we want to know about and to follow. So that would be a good reason. So the murmur and making that diagnosis leads us on to a track of continued surveillance. We certainly don't want to miss hypertrophic cardiomyopathy, 1 in 200, so it's not rare. And so that would be a very important diagnosis and would lead us to family screening of all first-degree relatives. And occasionally the murmur might be an innocent flow murmur, but due to an atrial septal defect, also an important diagnosis because over time that may lead to pulmonary hypertension. Next slide, thank you. So the red flag, if there's structural heart disease, all bets are off. If we have these PVCs, our patient's healthy, normal ECG, we say these are benign. There is no link between PVCs and sudden death if we don't have a diagnosis of structural disease. And once structural disease has reared its head, we say, yes, this is prognostic. Whether we can change that prognosis or not may depend on other factors, but it no longer are these beats innocent. Next slide, please. So now let's come back to our standard format again. And when we do the ECG, it's normal, but there's a little bit of bigeminy there. And that's important because now the question of what is this patient's true PVC burden? Because patients are often unaware of all or some of their PVCs, and if there's a high burden, then the PVCs sometimes can affect left ventricular contractility. What sort of burden? No one knows. Conventionally, we take a figure of about 10%. But my point is that if there are 2 or 3 PVCs on the ECG, that's not normal. That suggests that there may be quite a continuing burden, and that justifies a Holter. And if the Holter shows a significant burden, probably anything over 5%, just to be on the safe side, I would follow that up with an echo. Next slide, please. So here's just an example. We see trigeminy, 3 PVCs. Even though everything else says these are harmless, I'm going to do a Holter because I want to know how many of these are present over the 24 hours, how many are occurring when the patient is not aware of them. Next slide, please. So the red flag, frequent PVCs may cause LV dysfunction. If the PVCs are not causing symptoms and the LV is normal, I would not normally treat them, but I would keep the patient under surveillance. I would say, let's do another Holter in 9 months or 12 months, and as long as the PVC burden remains high, we'll need to keep following LV function. If the patients are symptomatic, that's different, and then we may say, well, would this be something suitable for ablation? Should we start an antiarrhythmic drug? Next slide, please. So now we've got the second part that was given by my colleagues, and now we've got a 40-year-old male, and now the palpitations are a little different. They are rapid and irregular, so obviously, yes, that raises the possibility of atrial fibrillation, also raises the possibility of multiple extrasystoles, either atrial or ventricular. Again, the physical examination is normal, but the 12-lead ECG is not. It shows LVH and strain, very abnormal. What can that be? Only one thing, I think. If this patient at 40 had aortic stenosis, it would have to be a bicuspid valve or congenital aortic stenosis, and we would hear a loud systolic murmur. But the physical exam is normal, so it's not that. And we've measured the blood pressure, and if the blood pressure is strictly normal, you're not going to get severe LVH from intermittent hypertension. So this is hypertrophic cardiomyopathy. Next slide, please. And so, next slide, thank you. So that's important because although in most people, like 99% of people, it's going to have a benign course, in 1% of people, it can cause sudden death. And so we're going to want to risk stratify that patient with an echo to see how thick the septum is. We're going to do an MRI scan to see is the fibrosis that's not shown on the echo. We're going to get some serial Holters and say, are there episodes of non-sustained VT occurring of which the patient's unaware? And if we found the septum was more than 3 centimetres, or there's repetitive non-sustained VT, or there's a bad family history with episodes of sudden death in people under the age of 60, we're going to talk seriously about implanting an ICD. So suddenly we've jumped from a very benign situation where we're all reassurance to a very important situation where we're contemplating an ICD. It's a dominant inheritance, and so we then have a responsibility to advise the patient that all first-degree relatives need to have an echo and ECG screening, and that if they prove to have the condition, that further follow-up and evaluation will be necessary, and we'll probably refer them to an inherited diseases clinic. There's a very good one at Auckland Hospital, and there'll be ones at other Middlemore and North Shore to consider genetic screening. Next slide, please. Let's go back to our first part again, go back to our 45-year-old female, and now say the ECG is not normal. It's got bundle branch block, again implying possible structural heart disease. Right bundle branch block is by itself benign. In an asymptomatic young person with right bundle branch block, I personally would not refer them for an echo. In this case, the patient's fronted up with some palpitations, and so maybe that weighs things slightly, and we will say, well, we'll just follow this up and get an echo. Occasionally, it may indicate important conditions. It might, if the right ventricle is enlarged, indicate a shunt, such as an atrial septal defect. And of course, rarely, it may indicate pulmonary hypertension. Primary pulmonary hypertension is a rare disease, but it's a very important disease. Left bundle branch block, on the other hand, most commonly is reflective of left ventricular disease, maybe a cardiomyopathy, maybe previous myocardial infarction. Sometimes it's purely electrical disease and there's no myocardial involvement, but it's still bifascicular block. The patient's going to have a 2% annual risk of syncope needing a pacemaker, and so left bundle branch block always needs referral and full evaluation. Next slide, thank you. And so the red flag here is an abnormal ECG, signals the need for a full evaluation. So I hope I've defended myself a little, that the first patient, the asymptomatic patient with first-time PVCs, classical history, missed beats, thumps, I would leave alone. If they see me, hand on heart, I hope I don't order an echo and I don't order a Holter. But you can see some of the other features that may come out in our discussion, which would lead me to a fuller evaluation. I'll be happy to take any questions. Thank you.
Thanks, Warren. That was a wonderful talk with some very good key pointers there. So one question's come up on my screen. How do you refer to inherited disease clinic?
How do I refer?
To the inherited disease clinic.
You can just refer electronically, just as you send any other reference, send it in, and as part of the triage, that will go through to Jackie Crawford, who runs a really excellent service with the Inherited Diseases Clinic. And it's a very good service because they will undertake the burden of following out the first-degree relatives, and it's not always straightforward because, as you know, families are sometimes dysfunctional, sometimes family members will be very resistant to any idea of an inherited disease, so it takes quite a lot of skill and patience to actually try and get that family screening as comprehensively as possible.
Second question, do we need to investigate high takeoff on the ECG? So palpitations with high takeoff?
Brugada syndrome. So, if we have a type 1 Brugada ECG, which is a cove, a rounded hill on V1, a clearly abnormal ECG, we diagnose Brugada syndrome. And then it's very unsatisfactory. We tell the patient there's a 1% risk of an event a year, and that event may be sudden death, but actually we don't have any treatment. We don't think that merits an ICD. We don't start you on quinidine. Very unsatisfactory. But the worst is the type 2. So we have a concave, slight elevation, let's say 1 millimetre in V2. Patient's otherwise perfectly well. That, by definition, is a type 2 Brugada ECG. Some people with a type 2 Brugada ECG, if we inject them with a calcium blocker such as asmoline or flecainide, will convert to a type 1. When do we do that? Well, when you send your ECGs in for me to report, I try, if it's just an asymptomatic ECG, I try to avoid the word Brugada. I might say there's a slight repolarization abnormality. I leave those patients alone. Conversely, if the patient's had syncope, I would refer them for an asmoline test. So now we've got the patient with PVCs and the slight ST segment elevation. I would take a very careful history. If in an extended family history there wasn't a shred of evidence of any premature or unexpected disease, the patient had no syncope, I personally would not do anything further, because I think any further intervention, the negative downside would outweigh the very tiny chance we're overlooking something abnormal. What you can do, as opportunity affords, is at some other time get another ECG, because the other thing about Brugada is that it's dynamic. On one day the ECG is totally normal, another day it might be type 2, another day it might be type 1. So it's quite nice that sometime if you've got 2 ECGs and they're both the same, that's very reassuring.
Thanks for that. Another question here. Saw a patient whose father was recently diagnosed with hypertrophic obstructive cardiomyopathy. Patient herself is asymptomatic. Does she need referral?
I think yes. Yes, I think so. So it's important that we arrange for some serial halters on that patient to look for non-sustained VT, of which the patient may be unaware. It's important to see, is there any dynamic outflow obstruction? There may not be any obstruction at rest, but what happens with the Valsalva manoeuvre? And is the patient truly asymptomatic with sustained vigorous exercise? Is there any, should we be thinking at all about any reduction of that outflow tract gradient if it's there? And just to go over the family history and make quite sure, like that drowning, sometimes, you know, the patient might think that's okay, but if we dig into that and find that, yes, the patient drowned in still water, we're saying, actually, this is a history of sudden death. So I think the answer to that is yes, it needs to be referred.
I think you heard the question a little differently. So the father had hokum, the daughter is asymptomatic and hasn't been screened. Should she be screened? And the answer would be, of course.
Absolutely, absolutely. Yes.
And then there's a question here on a 40-year-old with recurrent presentations of dizziness in the last 48 hours. How should they be managed in the GP clinic?
So dizziness. So much depends, doesn't it, on the total setting. If this is a 40-year-old woman who is trying to work part-time and has got 3 children at home and is getting no support from her husband, I'm not surprised that she's dizzy. And if her examination's otherwise normal, I'm probably not going to do anything. Yeah. On the other hand, if it's a 40-year-old woman who's a bank executive and suddenly she's sitting at a desk and come over and had to grip a desk in case she faints, yes, I'd take that pretty seriously, and I'd certainly get an echo in that person. Monitoring's difficult, isn't it? Maybe I might, if they've been recurrent, tell her about an alive core and try and get a symptom rhythm correlation.
Okay, well, I think that's all for the questions. Thanks very much, Warren.